Thank you. I want to thank Jeanette as well for giving her personal story. I always think that it's, first of all, very courageous to share and speak up in group rather than in individual conversation about this and share your personal life, your personal details. In the same way, I think that the perspective that you provide as patients is critical for us. We had a conversation with the board on Thursday night, which really shows that there are areas that really affect you as patients, which we as physicians don't talk about, we don't think about. And I think we really need to see how those agendas or experiences are different and where we can bring that more together. So it's partly the reason why, as president of the Canadian Society for Endocrinology and Metabolism, I want to bring patient perspectives in to help what do we need to teach about, maybe what do we need to provide research about, or where do we together have to work on advocacy. So I think your work here is critical in doing that. I want to thank you again. The task to talk about acromegaly, how it affects our organs, glands, and bones at the end of a busy day. I hope you all have still the energy to listen. If I speak gibberish, let me know. If I speak Dutch, let me know as well. Because sometimes I fall back into my first tongue, so hopefully it won't be an issue. Some things that you'll see is that some of the slides are similar as before. We might use them to different points, but we all search in the same fountain of knowledge that is there. And as you know, acromegaly is rare, and I think what this means is that for physicians you encounter in Emerge as the family doctor or other areas, they do not have experience with acromegaly. So that means that they have more difficulty recognizing it because it is always a matter of having some exposure to recognize things. And there will be a real difference. And I think even there are some endocrinologists who see very little acromegaly, for example, if their practice is more focused on other areas. So not every endocrinologist is the same as well, like not every neurosurgeon is the same. We talked about that. Dr. Tani talked a little bit about that it affects organs and bones. I think the real message is here, like Dr. Isat said. Every cell in your body has growth hormone receptors, and that can be affecting you. And we cannot predict exactly which cells are affected in individual patients. And that's why there will be some commonalities between you as you speak with each other. You'll also have areas where there's profound difference. I have the sweating, I don't have it at all. I have this, I don't have that. And so that means that the presentation is not uniform and the same, but varies a lot between individuals. And the result of that is that you need to identify what is bothering you the most at the moment and try to bring that in your agenda when you see your physician. Because when you come, I don't know of all this list of things, and this is only a quarter of symptoms that are there, what you see here, which ones are the ones that are most relevant to you. The second part, I would say, is that physicians tend to focus on things they can do something about or they can treat with. So they might be interested in your IGF-1 number. You might be far more interested in, do I have joint pain or not, regardless of what the number is. So what you see is that sometimes the agenda of the patient and the agenda of the physician is not aligned. And I think that's may cause some frustration when you go and speak with your doctor about what to do. Are they really listening to me? And my recommendation is that before you go visit and see your doctor, think about what are the top 2 things you would really like to address in this visit. Write them on a piece of paper and you go in and say, I want to know whether I'm going to lose my driving license. I want to know whether my symptom X is related to this or not. Can you address this in this consult? By doing that, you can try to have the issue that you most worry about actually be addressed. Because if you don't do that, there's residents coming in, medical students, doctors, images, other things. It goes so quick that you don't get a chance to address actually what your issue is. So I always like it when patients write down 2 or 3 questions and say, this is sort of my issues or my questions, what I'm experiencing, because then I can help to integrate that. I don't know whether this makes sense, but that's sort of my assessment of where we run into struggles between the interactions. Second part is because there is so many tissues that can be affected that it's often hard to address all of those in every single visit. If you look at all the list of things you should follow and screen, etc., that's a long list. And given the limited time that is usually for a consult, try to identify what's the most important for you, what you struggled with. And if you have access to your chart for blood test results, do that before the visit and figure out which one you're worried about. I'm worried about my IGF-1, I'm worried about my testosterone, I'm worried about my prolactin, I'm worried about my diabetes. So figure out which ones are the most important for you so that you can focus the visit that way. Because otherwise I think you may leave the room and say, hey, I didn't get a chance to talk about how this affects, how my mood is affected, whichever symptom it is. As you all know, the symptoms are across, and there are symptoms that outsiders can see. There are other things that you feel but nobody else can see. When it comes to blood pressure, we can measure it. When it comes to obstructive sleep apnea, we probably have to listen to the partners rather than yourself, because they might have a better sense of that. But fatigue or weakness, things like that, your energy level, those are things that only you can report to. And for others, it's very difficult to assess that and measure that. So try to say, okay, even if you compare, okay, we made a medication change last time, my energy level is better, the same, or worse. Because that information will be really helpful to see. Is this medication, it may do something on the numbers, but what does it do on how you feel? I think that's a critical part. Of course, you know that the goal of treatment of acromegaly is, as shown before, is to reduce or control tumor growth, to inhibit the overproduction of growth hormone, normalize the IGF-1 so those have no more the excessive effect on the tissues, to improve or prevent complications and reduce mortality. And the options we already talked about: surgery, medical treatment, radiation, and that's something I think should be done in a team, not by a single physician, but really need to be in a team approach. When we're talking about which tissues and other things get involved, that's where it comes to how can we prevent or reduce the effect of complications or other tissues involved, and what can we do to prevent earlier deaths than in the population. This we talked about, the medical treatment, focusing on the pituitary, focusing on the growth hormone effects or on the IGF-1 effects, and I will leave that for others to discuss further. Again, growth hormone affects tissues all across the body, and some of them we only find out more recently it's present. It is the things that you can see on the outside, it's bone issues, I think Janet mentioned the eye muscles as well. That is blood pressure and fluid retention that may happen. It may affect your breathing and metabolic things like the cholesterol levels, the glucose levels, joint issues as well. And again, with time, the number of organs that are involved is only increasing. So we have to think about acromegaly as a system disease, that it affects all organs rather than a single pituitary disease. I think talking about it as a pituitary disease actually limits what it really means for you as a patient. And there's cardiovascular disease, there's bone issues, there's metabolic issues, respiratory issues. There might be some other tumors. There might be bone affected, and it may cause osteoporosis or bone fractures. And I think a critical one is the quality of life. And I think that the quality of life falls under that category of things that physicians find more difficult to deal with. My quality of life is not as good. So they will try to find one or two things. Is it your joint? Is it you not sleeping? What is it? What I can work on? But you can only describe that. You need to identify how your quality of life is, how you're affected. Are you able to go for your walk so you no longer can do that? Are you having difficulty seeing things? Whatever it is. But that's, I think, your role, because you observe that every day of the year. You might see a physician 2, 3, sometimes 4 times a year, but that's very limited time comparing to the time that you struggle with all the effects of this disease. And again, what I talk about here is patients who've been diagnosed and confirmed with acromegaly, not a diagnostic issue, is it present or not. This is a slide that I think Dr. Praptani used as well, which is going back to around 2011. So this is about 15, 20 years ago, that at that moment, the results of the research showed that acromegaly was associated with an earlier death, more deaths than in others from similar age, similar sex as well. And what you can see here, that the most important area in there is cardiovascular disease, so heart disease, and cerebrovascular disease, which is strokes. So that's really the cardiovascular effect, and so we need to learn from that addressing cardiovascular disease, cardiovascular risk factors is critical in order to try to, in some way, deal with that excess of mortality. So this is how long do you live? And so this is, again, 2011. And so when it comes to cardiovascular risk, there are all kinds of factors that play a role. I mean, how many of you have a blood pressure machine at home? I think it's a fair bit. So I think it's important because when patients come to my office in the hospital, they'll have difficulty finding parking, you have to drive around twice, the blood pressure goes up, I'm late for the appointment. So it makes the blood pressure measurement less reliable. If you have measured your blood pressure at home, you measure a couple of times and you get the numbers, that information is really helpful to come to the visit for us to decide, do we need to maybe start blood pressure medication or adjust the medication as well. So again, in your preparation for your visit, if you have that information, it will make it helpful and more reliable in sense of is your blood pressure remaining high or is it only because they're parking garage. I call it parking garage induced hypertension. And so what you see, if you're looking at a graph for cardiovascular risk, you see on the bottom line, that's the x-axis, you see the age, and then you see with increasing age that the risk really goes up, and particularly after around the late 40s, 50s, and it continues to go up. And that's in the general population. You look at acromegaly, that sort of is at a higher level and at earlier age. So that means that what you want to do is bring that back to where the normal population is. And what are your peers like? And the good news is that if you're talking about acromegaly-related mortality, that more recent studies, now 10 years later, actually show that with adequate treatment of both the growth hormone and the risk factors had actually made that move to bring the risk of dying back from cardiovascular disease back to the normal population. So, and I think to me that's a major gain over the last 10 years. They've actually shown that that can be successful. So important that treatment actually has an effect there on this. So it's related to both the growth hormone treated and the risk factors. And of course, when you're thinking about cardiovascular risk factors, there are a number of things that play a role in there. But addressing those and asking about how am I doing with respect to the risk factors, and they were listed before, is blood pressure, it's smoking, it's cholesterol, it's diabetes, all of those different factors, in addition to your growth hormone treatments. And you can see that the presence of these factors in initial diagnosis is quite high. High blood pressure, almost half the patients. Left ventricular hypertrophy, which is a thickening of the heart muscle in response to increasing work that has to be done. There's a lot of variation. The quality of the studies varies in there. Sometimes there can be heart valve issues. Sometimes there can be irregular heartbeats. And actually heart failure, in which the heart simply cannot pump the fluids around sufficiently, is present in a lower percentage. But this is something that needs to be assessed and needs to be monitored, and it gets affected by growth hormone treatments. Because one of the things that growth hormone does is fluid retention, which makes the blood pressure go up and the heart's having more difficulty to pump that extra fluid around. So it's both the structure and the function that are important. So here, if you're looking at the effect of growth hormone and IGF-1 on those parameters, you can see that growth hormone functions on the kidney, which is on the right, to increase the retention of salt and water. Which also means that if you have high blood pressure and you have an increased growth hormone and you have a salt-rich diet, that all those together work in having more salt and water that make your blood pressure go up. IGF-1 works directly also on the heart and on the blood vessels as well. And blood vessels ideally should be fairly flexible and be able to move open. If they're very restricted, your blood pressure goes up. So blood vessel flexibility is important, and there's medications that can affect that as well. So surgery and medical treatment can improve those factors. So again, it's then the treatment is not only focused on the growth hormone, but also on other risk factors relating to cardiovascular disease. More recently, studies are looking at not only at what the blood vessels look like, but what is the calcium content in the coronary arteries, so the arteries that supply the heart with blood. And calcium score is something that is measured in there, but that's actually not really affected so far as we know in limited studies in acromegaly. So that means that when it comes to the measurement of coronary calcium content, which is now quite popular among cardiologists, may actually not fully assess cardiovascular risk in patients with acromegaly. So in addition, therefore, an echo of the heart in which they look at the size of the heart and its functionality needs to be done on a regular basis. And then stroke by itself is not necessarily increased anymore in acromegaly, but in patients who have had radiation in the past, that risk was increased. So that's been a reason, and overall, that the use of radiation has shrunk a little bit in how often we use it. But also the more modern radiation, I think Dr. Cosumano will talk about that as well, is likely associated with less or no increase in stroke prevalence as compared to previous strokes. So I think that's really the radiation and radiation are not the same. What you use for radiation, what the type is it, how well it is focused, plays a role. So I think that the effect is not the same as it was, but if you look at studies from the 70s, the 80s, there was clearly increased risk. So if you look at blood pressure elevation, which is present in about a third of the patients, there is a difference between the blood pressure elevation in patients who have acromegaly, which is the left column, and patients who have what we call essential hypertension, or blood pressure elevation for which we don't have a specific cause. Because in acromegaly, if your heart muscle has increased, you can see more of the ability to go back to normal, while that is not as clear in essential hypertension. The blood vessel function, the way they can sort of react, is more important, and that can be addressed with medication. Of course, the effect of growth hormone excess is only in patients with acromegaly, while patients with essential hypertension should not have growth hormone excessive effects. And the fluid retention and then also obstructive sleep apnea has an effect on blood pressure as well. So now you see that different comorbidities start to link together and have joint effects on your health. So the recommendations are to measure blood pressure, and I suggest that you measure at home as well, and there's other reasons for that, to have an echo at least as baseline, and probably at least once an electrocardiogram, and then upon indication as well. And depending on the findings, we may need to consider cardiologists. The trouble with consulting other specialties is that they will often have very little experience with patients with acromegaly. So what I try to do, and I think some others do that as well, to try to find one cardiologist where I refer to, rather than everyone goes to somebody else. And the same might be for other conditions as well. But we don't have a really good way of identifying those other specialties. Who has an interest in the relation between their specialty and acromegaly? And I think that's an area where the expertise could be enhanced by having some more dedicated frontline specialists. And then other risk factors to think about are smoking, diabetes control, blood pressure, cholesterol. So those all then come together in trying to deal with that cardiovascular risk. As you know, growth hormone drives blood sugars up, and that can increase the blood sugars causing diabetes mellitus, or at least insulin resistance. And those play a role in various ways for cardiovascular effects. So you have to, it has effects on muscle, it has effects on the liver to produce glucose, it has effects on the pancreas, that the insulin that's needed to get glucose into the tissues is no longer working as well, and then also it can change how the fat tissue deals with glucose. So there's lots of reasons why this metabolism gets affected, but the net result for you is that you may have diabetes, and typically monitoring will include monitoring of glucose and hemoglobin A1C. So that's what you should measure, and that should be done on a regular basis. And the same for cholesterol, it should be measured as well. And then there is standard medication we can use, diet, insulin as well. And again, this is both for treating symptoms and because diabetes is also a factor for longer term other risks, including cardiovascular risk, those should be addressed. So if you look at diabetes treatment in acromegaly, the different treatments have different pathways of how they affect. So on the right, you see insulin resistance. So insulin resistance means that it's more difficult for the body to get the glucose if it goes up to take it into the tissue. And that insulin resistance is increasing acromegaly, and if you normalize the hormones, and you can see that surgery and pegvisomant do that, they will then improve glucose control and diabetes. If you're looking at on the left, there is other things. It's the production of glucagon by the pancreas, which drives glucose release from the liver up, insulin secretion. You can see that the somatostatin receptor ligands, they work on both the insulin resistance as in the insulin resist. So they have multiple effects on those factors that play a role in the diabetes. And then finally, pasireotide, which you see at the bottom, has actually the most effects of driving blood sugars up because it affects insulin resistance as well as insulin secretion. And then if you go from the top, you can see that surgery and pegvisomant will have a beneficial effect on glucose control. The effect on somatostatin receptor ligands is a bit more neutral. There's some effect still. And then pasireotide tends to increase blood sugars as well. So patients who start that need to be monitored for developing and treatment of diabetes. Then lipid abnormalities can be present quite common. There can be all kinds of different ways to measure that. And they can be present in up to 50% of patients at presentation, and it may again improve with treatment. But the information, how well it does that, to predict in individuals how successful it is not clear. So because we cannot exactly predict who will respond or not, it needs to be monitored. And again, this is one of the cardiovascular risk factors. Then switching to respiratory disease, this is really the ability to breathe in and breathe out, and to then exchange and get oxygen properly into your blood as well. And of course, you can test that with functional testing, but who needs to be tested and why? Now, when it comes to respiratory disease, the pulmonary function will often focus on things like asthma and how well can you breathe in and breathe out. But what it doesn't measure by itself necessarily is obstructive sleep apnea. And that's one of the conditions that's most common in acromegaly. So who of you has had a sleep test? Okay, and who of you had to wait more than 1 year for getting the sleep test? So I think the real issue is that there are things that we think that need to be done, but that doesn't mean that they're readily available. And at least in the area where I am, when we request a sleep test, it's typically 1 to 2 years wait time before it gets done. And so this comes to how do we not only identify potential issues, but how do we create access to that as well? And how does that compare? And so to me, that's something is a concern is within our healthcare system, that just because there's an indication, it doesn't mean it happens today. It may take some significant time. And respiratory disease, including sleep apnea syndrome, is present in about 26% of all acromegaly, but if you have active acromegaly in which there is increased hormone production, it is more common. So better control of the disease likely makes it better. And the changes that are happening are present in the tongue and the throat, and of course you know that as well. And we have one of my patients, if there is a recurrence, the first thing she notices is the tongue increase. And so I think every patient has some of the telltale symptoms that for them are the ones that really say, okay, I think it's coming back. And for somebody else it might be sweating, for somebody else it might be something else. But if you have that, that's important to identify and inform your physician about that. So to diagnose obstructive sleep apnea, you need sleep studies. But who sleeps well in a strange bed in a hospital with all kinds of things around? So that remains an issue as well. So some people have the ability to do home sleep testing as a screening as well. So that might be another way of looking into that. So what you see here is that if you look on the left, the normal, and you see the tongue size, and at the right, you see that with sleep apnea, the tongue can start to block the airways, and that's partly what causes the snoring, and it's partly also why changing to your side may mean that the tongue is less forward, and sleeping on your side may treat some of that. What happens with acromegaly is that there is increase of the walls of the throat as well as the tongue, which makes it more likely that you get into these issues. Then when it comes to bone, and again, I can only touch briefly on all those symptoms. You could, about each of those slides, you could actually spend an hour talking about the research study. It's like it's really scratching the surface, and I may not address all tissues. So only over the last years, it becomes clear that growth hormone and IGF-1 are not only involved in bone remodeling, but also that there is an increase in the risk of vertebral fractures and other fractures. If you go back 10 or 15 years ago, we saw that with acromegaly, the bone would actually get denser, and that would be protective. But it turns out that while the bone is denser and there's sufficient calcium in it, the structure is not necessarily the same. And as engineers probably will tell you, is that it's not only the mass of it, it's also the structure of how it's functioning that has an effect on the risk of getting fractures. So despite an increase in bone calcium content, there still is an increased risk of fractures. And that means that just a bone density without actually taking X-ray or another way of assessing if there's fractures, it's important that you just don't rely only on the calcium content, which most osteoporosis measurements will focus on. So that means that the tools that are available traditionally with bone density might not be the best ones. The screening X-ray might be a way to address that. Trabecular bone score, which is not the test that's now coming up as well, may be useful. And then you can also say what are other factors that play a role, and if men have a low testosterone, that will contribute to the risk of osteoporosis. Are you lowering your vitamin D as well? So that's then another factor, and maybe taking vitamin D is something to consider. Joint pain, probably one of the most devastating parts of acromegaly and one of the ones that least respond to medical treatment. It's present double of the general population, and it's mostly the bigger joints. And what is important that is in the development of joint pain is actually there's two phases. The first phase is that if you have a joint, in between there's cartilage. That cartilage first increases in size, and that can cause hip pain. That's reversible. So if you have earlier treatments, you can get that back to normal. Once the bone changes and this becomes disjointed and becomes affected, then it becomes irreversible. So which makes also the case for earlier screening and for better treatment to get growth hormone levels normal. The other effect of that is if you talk to the general orthopedic surgeon, they will typically look, and they're used from osteoarthritis that most people have, that the cartilage has disappeared, so the bones sit on each top of each other. So if they see that cartilage present, they think, well, oh, it's not too bad. But it's still a change because of the acromegaly. And so that makes you wonder if the assessment of x-rays in patients with acromegaly should be done differently than in the general osteoarthritis. And I think there's some information suggesting that, but I don't think we've really well established that or how to address that. But again, earlier treatment is better in getting better results. So early diagnosis and treatment, like I said. Then pituitary insufficiency. It came up that you can develop pituitary insufficiency just because of the tumor pressing on the normal tissue, getting paper thin or disappearing. It may sometimes be an effect of surgery, and it can be an effect of radiation as well. So you can develop pituitary insufficiency at various stages during the treatments. And those all are individual conditions that need to be addressed. Adrenal insufficiency is an important one because adrenal crisis in which you have insufficient cortisol can be life-threatening, so that's really important. Thyroid hormone needs to be normalized. Testosterone or estrogen needs to be normalized, what's normal for that age group as well. And all of this can be treated. And just talking about pituitary insufficiency, when I teach that, I spend about 2 hours to students to talk about that. So again, I don't have the time to address all of it, but that's something you need to be aware of and needs to be evaluated after the surgery. There's always discussion about cancer, and we talked about that a bit. The theoretical idea is that if you have too much growth hormone, you stimulate tissues to grow, and that could stimulate to that changing into a more cancerous way of doing that. So long-term debates about is the risk for colon cancer increase? It probably is a little bit if you don't screen, but certainly there's a risk for colonic polyps. There's a smaller growth which are still benign, but there are pre-stages which can develop into cancer. And this is why the recommendation is to do colonoscopy at diagnosis or at least of the age of 40. Because of course the question is, if you have a patient diagnosed at 20, what age do you start screening? And the recommendation is possibly it starts 40. And the guidelines of that are developing and changing. And so this is just a small table, and I don't expect you to read all of it, but it shows that there is 4 different associations of guidelines, and they all can be slightly different. But the principle is, at diagnosis, you probably need to be screened, and then depending on the findings, if it's all completely fine, then you can wait 10 years. If there's polyps, then this should be done as usual for polyps and have follow-up maybe after 5 years or something like that. But guidelines can interpret things a bit differently in the literature, and that can sometimes cause confusing. Why is it for me 5 years and the other 10 years? What guideline does someone use? I think the quality of life is an essential one to address why we don't do that well. As you can see, the symptoms of acromegaly on the left and the biochemistry related to that, that's probably the part where most physicians will focus on. But what does it do when you think about that? How does it affect people when they look at themselves, body image? What's the perception of how you're coping? How is it working? Does it affect your mood? Does it cause anxiety? Is there cognitive changes as well? And how is your function? How's your memory function? All of those factors play a role, and that becomes then a part of a chronic disease. And having chronic disease really is an issue where the healthcare resources don't really deal well with that in how to monitor, what resources to provide available, and how frequently to monitor as well. So I think there's still areas to work on. Does radiation play a role, and how to measure this, and how do you measure the change? So for me, if you come into my office and you have reflected, okay, how are you doing compared to last year? I'm the same, I'm better or worse. That will already help me to say, do I need to try to address this? I may not be able to address it, but at least we put it on the table rather than, I don't know how to deal with quality of life, let's move on what your hemoglobin A1C is. So when it comes to quality of life, there are questionnaires that are being used. There are disease-specific questionnaires, for example, the Acromegaly quality of life, or patient questionnaires like the PASQ. There are generic questionnaires that are being used as well, and there are some that are domain-specific, for example, only focusing on joints or on the mood or otherwise as well. And you can imagine that it's very difficult to every visit fill out all these questionnaires. It would take you a day extra for your visit. But to have a questionnaire and to not follow up or not having comparison is also difficult. If I have a questionnaire and you score, let's say, 6 out of 10, I would like to know, has it changed over time or not, and how is it doing? But that's still, I think, a challenge. And one of the things we talked about earlier is that it may be helpful to have access to questionnaires, and if you feel, for example, that you have more snoring, that the questionnaire related to snoring, that you fill it out, and when you come into your office, that you say, hey, my score is now indicating that I might have an issue. Can we talk about that? Because that might make it easier for the physician to decide what's the next step to do. Recently, and this was actually interesting that Janet just talked about the eye muscles. We actually did a study, and it was the first one that has been done systematically to look at the extraocular eye muscles. So it's the muscles around your eye that coordinate your eye movements. And we looked at those in patients with acromegaly and compared with patients who have a pituitary adenoma that is not producing any excessive hormone levels. And what you can see here is for 4 different muscles. You can see in the light gray what the maximum diameter is for the patients with a normal, non-secreting pituitary adenoma, and in black, the ones with acromegaly. So you can see that the size of the eye muscle is clearly increased in the patient with acromegaly. And this was done at the time of diagnosis, because we used a CT scan that was done in planning for the first surgery. So again, this illustrates that the effect of growth hormone is on any tissue, as long as we try to develop the tools to measure that. What we don't know yet is whether adequate treatment results in normalization. I'm just looking at where are we with the time. Okay. So bringing this back, this is again emphasizing that acromegaly growth hormone excess affects all these tissues, some which are easy to see for your partners, for people around you, some who are not able to see, but it can affect all of those. And the result is the difficulty for you is anytime you have a symptom, what am I feeling? Is it related to acromegaly or not? And I think that's an ongoing challenge that you'll face, is because not everything in life will necessarily come from acromegaly. The same way you cannot exclude it without addressing it as well. And I think that creates an ongoing challenge, and that may contribute to the quality of life worries that patients have. So control of acromegaly can reduce comorbidities, and this is the same slide as we just saw before, so you can see that we borrow from the same slides. But you can see that going from undiagnosed to intervention to disease control, in those steps you get better and better control of the various symptoms that are present or the risk factors that are present. And that is in the end both resulting in improvement of quality of life as well as improving that you get back to the mortality of others in the population as well. So I think that's really important. And that affects then, I think, in the small letters on the right, that's actually what's really important. What's your mortality? Are you able to work? How's your quality of life? How does it affect your financial situation? It's in the smallest letters, but I think that is what, again, the patient's interest and agenda is more on how does it affect me in this area. And again, I think that's why I really like the input of you in what do we need to address. How do we link the treatment effects to those factors that affect your life directly? So, but there is a potential reduction in comorbidities as well. What you see here is that if you have management of acromegaly, you prove growth hormone control, that it affects your SMR, which is standard mortality ratios. How is your mortality related to others in the population? Improvement in growth hormone, improvement in IGF-1 results in doing better with respect to hypertension, to diabetes, to heart disease as well. So I think it's a role that we need to continue to focus on. How to get there easier, how to get there more quickly. And one of the ideas of the consensus of the Canadian guidelines that Dr. Izat showed was to try to help that to convince insurance companies that we need to more quickly go to the next treatment level in order to gets to the control of the growth hormone overproduction, the IGF-1 level. So the sooner we get there, the more we have likely a long-term beneficial effects. So how are we doing in Canada? So the problem is that we have done surveys in Canada, but they are now 10 years old. And I think what Dr. Izard will talk about tomorrow is that monitoring how we're doing will really help and inform to see whether we are doing better or maybe not, and what do we need to focus on. But if we don't measure, if we don't have something to compare with, it's critical that we work on that. So what you can see here is that it's very common to have comorbidities present, and you see for the different ones at the bottom, where there's high blood pressure, where there's depression, where there's obstructive sleep apnea, that they're quite common in patients with acromegaly. You can see that the high blood pressure was up to 50%, and some others, the percentage goes down, but it's present. And again, every visit you cannot address all of those, so you have to try to identify with your physician what are the most important ones to work on. But what this also shows is if you're looking at those, is the 100% means that that condition is completely controlled. If the blue is lower, it means that it is present, but it's not controlled. And you see that quite a few of those, the control is not as good as it should be ideally. And it shows that there's everywhere there's gray areas, there is room for improvement in how we're doing as a treatment. So I think there's still a lot of improvement that could be done based upon 10 years ago. I don't think that we're doing any significantly better right now. I think that the pandemic sometimes has caused some delays in things as well. But if we don't measure how well we're doing, we don't know what to focus on for improvement. So this again showed that the comorbidities are not well controlled, and this is, you have to remember that this is filled out by people who do acromegaly, have an interest in the condition. This is not filled out by the family doctor and endocrinologist who has only one patient. So it is possible that those who see less patients even have more difficulty achieving that. We don't know, but that's a speculation. Typically, if you're treated by somebody with an interest in the condition, or a surgeon who has an interest in the condition, you will get better results. So I think that is really some significant improvement that can be done. And then the other part is, again, that we manage by many different specialists. But if you go see a cardiologist, a rheumatologist, orthopedic surgeon, ask them how many patients with acromegaly have you seen. Has anybody asked that? What's the response? Any thoughts? So I think often it's like I've seen one patient or two patients, but it's not a high experience volume. And it means that you have to then advocate for yourself, and we have to try to provide documentation that say, this is how you should think about acromegaly, let's say joint issues, where it's the same or maybe where it's different. I think that's education that we need to do as a group. So I think the challenge is to have adequate control of acromegaly and of acromegaly-related comorbidities and complications. And I think it requires all of us together to work on that and to improve that. I think there's a lot of work to be done, but the same way, as a group, if you compare over the last 10 years, you've really done a lot. You've brought this to the forefront of the agenda. You create attention for this, and I think a meeting like this is a perfect example of that. So I want to thank you for doing that. Yeah. Yeah, I think we need to think about it. And also think is what is the most effective strategies to improve as well. So finally, I want to summarize some of the recommended screening for acromegaly. So what is the current guidelines say that is important in monitoring during your visits? And you can see that when it comes to cardiovascular disease, it's blood pressure, maybe 24-hour blood pressure, echo of your heart, maybe an electrocardiogram. It's the Epworth scale, which is the screening test questionnaire for obstructive sleep apnea, and maybe an actual sleep test. There's bone issues, when has that last been done? The joint evaluation, the colonoscopy, metabolic symptoms, and all of those in there, and then quality of life questionnaire. So there's a lot of things to monitor, and it can be a bit dazzling and overwhelming to do all of that. This is not meant to review in detail, but just to show that there is things to monitor. It's cardiovascular, it's respiratory, it's musculoskeletal, it is metabolic effects, it's neurological effects, then neoplastic effects, mass effects, quality of life, So it really shows that this is quite an extensive list. And again, if you say, can identify what's most important, that is for you is helpful. Also knowing when was your last colonoscopy done. If you come in and say, well, last one was done 4 years ago, that helps me that I don't have to go look it up and spend the time on that, because the time I spent on looking that up, I cannot spend on other things that you have. So it helps in your to be proactive for your visits. So and then there's various monitoring and things. I'll skip these for now, but we'll put them into the slides. But in summary, it's important to diagnose, to have suspicion for it, and sometimes needed to have a confirmation glucose tolerance test. The goal of treatment is not just the numbers to be right, but also tumor control and control of the comorbidities, and in the end, better quality of life for a longer duration. And I think we have to keep that in mind, that we really focus on that end effect and not just the steps in between. So finding surgeons who have experience is important, because the first surgery is your best chance for cure. And I think that having centers who have dedicated surgeons doing this is really critical. But again, ideally that is as part of a team where there's the experienced ENT, there's the endocrinologist, there's the nursing staff around, the OR staff. All of those are equally important. It's never a single individual. It is always the whole group in the leading up to the surgery, and then the same following after it. And how do you follow that? So I think team understanding is critical. And I can tell you that we have one of the ENT doctors who frequently does pituitary surgeries. And because he's seen more patients with acromegaly, he has now diagnosed several patients that he was the first one to see for another sort of sinus-related issue. And it looks like, hey, you may have acromegaly, and diagnose them. So I think this again shows how important it is exposure. And then maybe we need to have to train more ENT doctors as well as all the other specialists. There can be probably 20 specialists who can see you for a condition. And one case report I've seen was from a patient who had seen 20 different doctors, and had for each doctor had the condition that was related to acromegaly, whether it was a polyp, was other things like that. But nobody put all those things together, and the diagnosis was delayed by 5 years. Yeah. So I think that's experience that you may well have. Anyway, that was what I want to talk about. I want to thank you for your attention, and we're part of the panel.